Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. This is Reem Naguib, lecturer and preceptor at the Clinical Pharmacy Department, King Khalid University. I'm gonna start today with some major cardiovascular disorders. But before we start, we're gonna have go through some concepts, in cardiology and while you are reading any major guidelines in general. So let's get started. Okay, the first thing we're gonna start with is how to apply a major concept, that is the class of recommendations and level of evidence, to clinical strategies, treatments, and diagnostic testing in patient care. Okay, so when you're seeing a recommendation in any guideline, you need to see what is the class of this recommendation and what is the level of evidence supporting this recommendation. So the first class is class 1, okay? It means that this treatment is indicated or highly recommended, okay? That's to say the benefit is much greater than the risk if you apply this treatment. Class 2 recommendation, as you can see, it may be class 1, 2A or 2B, okay? The wording used to express such recommendations are either should be considered for class 2A or may be considered at class 2B. As you can see, we are getting weaker recommendations as we go down this list. Okay, so class 1 recommendation is much stronger than class 2, than class 3, definitely. So class 3 means it's not recommended. That means that the benefit may be equal to the harm, okay? So it's not beneficial, or even this is a harmful intervention, okay? The second concept is the level of evidence. That is to say, the amount of evidence or the amount of studies present to support such recommendations. So if we say class or level of evidence A, that means that these data are derived from multiple randomized controlled trials or meta-analyses, which are the highest at the top of the evidence pyramid, if you remember. Okay, then there is the level of evidence B, okay, which means that these data are derived from single randomized clinical trial or large non-randomized studies. As you can see, class level of evidence A is clearly much stronger than B, okay? And lastly, level of evidence C, which means either consensus of opinions, that is experts' opinion, okay, or even small studies or retrospective studies or registries. That is definitely much weaker than B and A. So let's catch up, okay? If you say class of recommendation, we mean the benefit versus risk, okay? And we say level of evidence, it means the amount of evidence to support this recommendation, okay? So let's move on. The second concept we're going to talk about is the cardiovascular risk factors, okay? Cardiovascular risk factors. We're going to use it in the context of hypertension, in the context of dyslipidemia. So these are described as the major cardiovascular risk factors, okay? If these factors are present, you have a high risk of getting cardiovascular diseases, okay? These factors can be classified into modifiable risk factors or relatively fixed risk factors. So modifiable means you can modify, you can change it. If you change these risk factors, you can reduce your CVD risk, okay? On the other hand, relatively fixed risk factors, that means either you cannot change these risk factors, like your age, like your gender, okay, like your family history, okay, or even if you change these risk factors, they may not reduce your cardiovascular risk, okay, like psychosocial risk, stress. So let's go through the modifiable risk factors. These are the factors that you can change and subsequently change your CVD risk, cardiovascular disease, okay. Like the well-established risk factors like cigarette smoking, second-hand smoking, diabetes, dyslipidemia or hypercholesterolemia, overweight and obesity, physical inactivity, unhealthy diet, okay? On the other hand, relatively fixed risk factors like CKD, family history, increased age, your gender, okay, low socio-economic and educational status, obstructive sleep apnea, and psychosocial stress. These are factors that you cannot change easily. The third concept, how to integrate the previous risk factors into estimating your total risk. So someone who has one risk factor definitely has less cardiovascular risk than that who has 2 or 3 or 4 or 5 cardiovascular risk factors. So in patients with hypertension and dyslipidemia, these are major cardiovascular risk factors, we can actually estimate the 10-year ASCVD so we can make treatment decisions, okay? So you can estimate your chance in the next 10 years of getting atherosclerotic cardiovascular disease, and this is a very important abbreviation. Okay, so what is atherosclerotic cardiovascular disease? It is defined as the first CH death, that means coronary heart disease death due to coronary heart disease, non-fatal MI, or fatal or non-fatal stroke. So this is what we mean by ASCVD. So you can calculate your 10-year risk of getting these outcomes or these diseases. There is a very nice equation, okay, that's called the pooled cohort equation, okay? It's available at this site, by which you can calculate your risk or even anybody's risk. Actually, it can be used to estimate the 10-year cardiovascular risk in patients 40 years to 75 years precisely, okay? We're gonna talk about this later, how to estimate the risk in those above 40 or less than 40 in the dyslipidemia topic. So let's take a look at the factors, okay, needed to be inserted into the equation in order to get your risk calculated. So you need to insert your current age, and if you can see, it's written between 20 and 79. Actually, when you get to enter the age, okay, it's only gonna accept those who are, as we said, 40 to 75, okay? So this is just theoretical. So the second factor is sex, race, okay? Because Afro-Americans have a higher chance of getting ASCVDs, okay, than whites and others. There is the systolic blood pressure, diastolic blood pressure, total cholesterol, HDL cholesterol, and LDL cholesterol. Is there a history of diabetes? Is there a history of smoking or current smoking status? Is the patient or is the person on hypertension treatment? Is he on a statin or on aspirin therapy? These are the treatments that reduce the ASCVD risk, okay? And then you can use this equation to calculate the ASCVD risk at multiple follow-up visits, okay? So you can see this item here, okay? To modify, to see if the medications you are taking are modifying your risk or not, okay?